morning's panel is composed of people who walk the talk on clinical interoperability, have seen the good, have seen things that have been challenging, and we're really looking forward to the opportunity to share some of their experiences here today. The format of the panel is I'm going to do rapid-fire introductions down the table, and then each of our panelists will have a short introduction in terms of their journey, their experiences, and then we're going to move into a more dynamic and open Q&A. I've got a bunch of questions ready, but we'll also open it up for others who may want to ask questions, and they're all now glaring at me because they know what questions I might be asking, but opening it up provides more options for creative discussion. In any case, let me start with the introductions. So, immediately next to the podium, I've realized that it's my right but your left, so left and right are going to be completely confusing. Paul Bazin. Paul is manager at Loblaw's Pharmacy in Swift Current in Saskatchewan, and we are incredibly grateful that the snowstorm there held off just long enough for him to arrive here today. He's also a peer leader in Saskatchewan with the peer program. Next up, Phalen-Kelly, who is a nurse practitioner, was the first nurse practitioner in Canada, in fact, running a program in inflammatory bowel disease. And she's with Capital District Health Authority in Nova Scotia, which hasn't yet changed its name, so I'm delighted that I can continue that introduction. Next to Kelly is Amanda Condon, who is with Access River East in Manitoba. And both Kelly and Amanda actually were representing leading practices that were identified through the process that we went through with Accreditation Canada. Next to Amanda is Keith, who is now very jealous that he wasn't identified as a leading practice because he didn't apply. But Keith Wilson, who's a family physician in New Brunswick and has been very involved with the EMR program in the province as well as national work. And next to Keith is Stephen McLaren, who is a family physician down the road at the Markham Family Health Team, and as with Keith, has been involved with the EMR program in many ways, a peer leader, and everybody on the panel has contributed through a variety of our clinical consultations and other processes to work across the country. So without further ado, Paul, do you want to kick us off in terms of your journey? And the microphone should work at your place.
Sure. Okay, perfect. So as she said, my name is Paul Bazin, and I'm a managing pharmacist in Saskatchewan. In Saskatchewan, we've been really fortunate over the last few years to develop more and more access to digital information. So we've had something called the Pharmaceutical Information Program for quite some time. We refer to it as PIP, and that's our DIS system. That's where we have access to medications dispensed in the community that we can track anywhere in the province. But fairly recently, over the last few years, there's been a new program been released called the EHR Viewer. And in this viewer, we have access to lab results, discharges, immunizations, chronic disease management, and soon to be diagnostic and imaging as well. And so with this type of information, it totally changes the way a pharmacist can practice in the community, because we can now utilize our knowledge and expertise in drug management to better provide patient care by adjusting medications based on kidney function or liver function, providing recommendations on management based on the way kind of the trending is going with their labs. So having access to that information totally changes the game. I was a pilot store for this lab viewer, and it's been something that not only have we as practitioners greatly appreciated, but our patients notice a huge difference in what we're able to provide to them. So it's a whole other level of care that goes far beyond what we've ever been able to do before.
Great, thanks, Paul. So interoperability, making different scopes of practice and different patient care possible. Kelly.
And hi there, I'm Phalen-Kelly, and I feel a little bit disadvantaged because I know you guys have been here for 2 days and you're all talking about interoperability, and I figure you probably have all solved all the world's problems by now. Anyway, I'm going to tell you a little bit about my journey. Imagine you're a part of a practice where you're one of 2 nurse practitioners who works in collaboration with 10 gastroenterologists, and you're responsible for the chronic care of 1,700 patients with inflammatory bowel disease. That is Crohn's disease and ulcerative colitis. Then, wonderfully, new medications are released that significantly improve outcomes for these patients. But unfortunately, they come with serious side effect profiles that need careful monitoring of both patients and the patient's blood work. Now imagine a chart room filled with 4,000 to 5,000 paper charts from practice of these 10 gastroenterologists. Your IBD charts are in there somewhere. You have no way of knowing how many patients you have, how many patients have ulcerative colitis, how many patients have Crohn's disease, what percentage of your patients are on immunosuppressants or biologics, and if your patients are getting their blood work done when they're supposed to. Clearly, you have concerns about safety and overall quality of patient care. The situation, although I'm sure it's not that unusual, is what drove us to move forward. We built a team that included our physician partners, administrators, health informatics, and IT. We demoed many possible industry solutions, but because our district was in the middle of many major IT changes and because we just simply didn't have a budget, we couldn't use industry solutions. Instead, we adapted an application that was built for Cancer Care Nova Scotia, and then Casper for IBD was born. Now, we're without paper charts. Casper lives on Capital Health's clinical portal, along with scheduling, diagnostics, and labs. All of our clinic visits are done electronically with the aid of disease-specific drop-down menus and Dragon Medical Practice Edition dictation software because I type really poorly. Our system was designed to use disease-specific analytics to evaluate response to care. I know exactly who my patients are, their disease, its location, and its severity. I know what therapies my patients are on, and I can quantify the response to therapy. We are now just starting to tap the research potential of this. At the end of each visit, a letter is produced that goes to the family doctor based on the queries asked during that visit. This letter is also immediately available on the hospital's permanent health record. Casper is a web-based solution, and this has allowed us to set up satellite clinics within the district. This undertaking was sometimes overwhelming, and certainly not without issues. We do believe that the quality and certainly the safety of the care we provide, however, has significantly improved as a result.
Great, thank you. So interoperability as a tool for changing clinical management and safety.
Huge.
Amanda.
Thanks. I'm Amanda Condon. I'm a family physician from Winnipeg. I'm going to share with you my journey with e-health technology. So when I was a resident, all of the family medicine clinics that I trained in had electronic medical records. And when I started practice, I started in a clinic that had paper charts that I didn't know how to work because I hadn't ever worked with a paper chart in a family doctor's office before. 3 years later, we implemented our electronic medical record across our health authority in Winnipeg for the community clinics. And at the time, I was the physician champion because I thought electronic medical records were a great place to document. I didn't have to handwrite, and everything was sort of neatly organized. And then over time, I came to realize the importance of data quality, the potential for practice improvement by keeping good records, the challenges with doing that when we're using a shared record across 30 sites, and the importance of physician champions or clinical champions in making sure that we're using those systems appropriately. As we've gone on to develop new systems and a new program specifically within our team where we're looking at improving the care for complex patients in the community and partnering with home care, using the tools that we have, so our electronic medical record, our electronic health record in Winnipeg or Manitoba, and using all of those tools together to be able to optimize the care for our patients. Currently, the interoperability is not super interoperable, but that when we're able to use the tools, they're able to still provide benefit for us to improve the care for the complex patients, but also for all of our patients.
Great. Thanks, Amanda. So interoperability as a journey, but as some of the glue across settings, across providers for complex patients. Keith.
So notwithstanding my colleagues, I started my IT career with a VIC-20, I think, which probably some of you know. But when I started my practice just over 10 years ago, we had begun the implementation of our first electronic medical record within the provincial hospices of the community health centers, which is where I worked. And I must say that participating in the RFP process for that was interesting at best, which I'm sure a lot of people would agree with that had participated. ultimately we selected a product and began implementation. And you may remember those first generation, maybe pre-first generation tablet PCs by HP. We thought that was going to be great to use with wireless technology in our clinic to go room to room. Unfortunately, due to the physical infrastructure of our facility, i.e. lots of old, it was a very old building with lots of beams and whatnot, every time you walked around the corner, you'd lose your connectivity, which meant that you had to log in. There was no SSO back in that day, I can tell you. You had to log in 4 times to get back to where you're left off. Then came the saving grace. Then, and oddly, this is how I met Lynn, was the utilization of thin clients, otherwise known as Sunray technology. Well, that was the game changer for us, because for ages we had been blaming the EMR for all our problems, but it wasn't the EMR. It was the technology that we were using to support the EMR. Interestingly, our calls to the help desk, actually went down dramatically once we had this technology in place. And later, I had the privilege of being involved, along with Marion Long, with the provincial EHR development. I had the opportunity to sit both on the steering committee as well as on the clinical work group, which actually provided completely different perspectives on the same problem, and I found it immensely helpful. And interestingly, at the time, EMR before EHR was a cry that a lot of clinicians, you would hear them say. But you know, in hindsight now, I mean, our success in New Brunswick, I think, would not be there if we didn't go the EHR first with the help of Infoway. So finally, I'm where I'm at now. This is over 10 years later. I've set out, left the community health center, set out a new teaching practice, a group practice, and we've gone with our brand new provincial implementation of an EMR program, which is done slightly differently than the rest of the country. And interestingly, though, as part of, similar to Amanda's issue with interoperability, I had interoperability in terms of lab and DI in my old EMR. And when I migrated to the new system, of course, the EMR is not integrated yet. We're in transition at this point. But holy cow, going back to paper, I never wanted to do it, and I still do not want to do it. But a year in, and we're almost to the integrated phase, which will hopefully save a lot of time. And then we're looking at e-referrals, and we're also looking at possibly integrating some teletriage data into our EMR directly with some e-booking stuff thrown in for good measure, you know. So that's sort of my briefish story. Anyway.
Thanks very much, Keith. So interoperability as something you've experienced and desperately want back, and even better. Stephen.
Our family practice group owes a lot of our success actually to all the physicians in the office that were naysayers and did not want to go EMR. So we sat in our office and we looked over the grassy cornfield at the hospital, and the naysayers said, "You're not going to print a piece of paper from the computer in the hospital, have our secretaries go over there to our little wire basket, pick up a stat, come over here, scan it, and put it in our in basket in our computer. Fix that problem, and then you have buy-in from me." So they challenged us to actually do something very smart. Our go live with EMR in 1999 was a contingent on a go live with electronic interfaces. So we developed unilateral interoperability from our key suppliers of information into our EMR. So our two big suppliers in town were MDS, or Life Labs, and we were able to stream about 80% of our patients to Life Labs for outpatient labs, and we're very brand loyal to our local hospital for all our diagnostics. So DI, cardiorespiratory, asthma clinics, diabetes clinic, fracture clinic, it's all at the local hospital. So we had an interface to MDS, which flowed electronic lab as discrete lab fields into our EMR, and we had an interface from our local hospital that delivered all the lab and all the typed reports, fully searchable, in context with all the little taglines, which actually served as great metadata, into our EMR. So having that right from day one, we were then able to bring our paper that we were still getting the 20% of labs where people went to other labs. We dutifully data field entered every single piece of information that came on paper by hand into the EMR. We still took all our consultant notes that came from the community on paper, scanned them, OCR'd, put them in the EMR. We went from every staff person filing to 1.5 FTEs managing all our information for all our providers. and being up to date every 2 hours. So we had almost real-time flow of incoming data right from day one. So an incredible unilateral interoperability experience right from the time we turned on our EMR. So all of a sudden we have searchable data. There's no hybrid. There's nothing stuck in paper. There's not pap smears floating in paper and pap smears in the EMR. It's all in the EMR. So then we're able to apply analytics and have a look at what we're doing and start to reshape our practice based on data that we had. We were very quick to get chartless because we didn't need charts anymore. So then we're able to recoup office space, bring in new providers, and actually reap all the benefits that we hear about in terms of the business case. So not only was our business case better and our overhead reduced, but our actual clinical practice based on data had improved. Our next interoperability steps were to network with interfaces to the other private labs, so we stopped data entrying. And then the latest, greatest thing in Ontario as we migrated to our new platform of EMR was integrating OLIS, so Ontario Lab Integration Services. It's as simple as a button when you're in the chart that recognizes who you are, recognizes who the patient is, feeds all those things to OLIS, brings up the screen, and all you do is ask for a date range of lab tests. So now when a patient says to me they had their pap smear done at the birth control clinic at university, I'm very happy not to do the PAP again. I'm very happy not to order another TSH, because in the real time that it just took me to make that sentence, I've got the lab from OLIS, and it's in their chart, and it's been signed off. It's that fast. So those type of interoperability experiences, even for the naysayers who drove that positive change to a man, to a person, to a woman in the office, they're not going back to paper. And as a group, we're definitely being able to share the rewards with our patients.
So Stephen, you've actually already sort of started to talk about what I wanted to talk about next, so the drivers of clinical interoperability and its urgency. And I guess as much for the naysayers as for the people at the forefront, the people who had the vision, are the drivers different? Are they the same? What do you see driving on a go forward?
Key drivers, our current key driver just from the ground up is our patients. They want to communicate with us electronically. We do not have that interoperable solution at present, but they are the #1 people that want to talk to us electronically. If I think of specialists and hospitals and CCAC and long-term care, they're not asking like the patients are. Historically, a key driver for interoperability for us was anybody that thought like an investor. So if you think as a physician putting your money into your computers and your electronic medical record, hopefully at some point your mind goes, I got to get more out of this. This is investment, where's the return? Mm-hmm. And so you start to look for those returns and you harness the power of your EMR. And then there's the investors that are jurisdictions, the LHINs and the province of Ontario and the country of Canada that have invested in electronics and they want to see some return. So we have those drivers currently as well that shape our practice and definitely make us dig into our EMR to be able to give the answers required.
Great. Anybody else want to add to that? Key drivers of interoperability and the urgency of it.
Well, sorry. Two things that sort of struck me about that question is timeliness and access, and that has always been an issue in our practice. I mean, most of my patients are quite low socioeconomic, so the demand for the electronic communication is not quite the same. But what is the same is the patient context of somebody coming into the office. As an example, or even before I give the example, it really strikes me that clinician time is precious, but even more so patient time is precious. The number of times that patients have come into an office where you don't have the information that they were told, follow up next week with your family physician because they'll have the results of blah, blah, blah. Well, chances are you don't have the results of that if you're not getting it electronically. And of course, I had forgotten all of that because I was integrated before, now rate not so much. Although we do have context integration with a clinical viewer, which actually allows us to quickly get into the same sort of information that Steve was talking about. But as an example, last week I had, no, this was a few weeks ago, I had, no, it was last week. Look, it's what, Thursday? Wednesday? I don't know. But anyway, I had a patient that was brand new to my practice. Now, we're not fully separated from the provincial systems. I mean, we're integrated with client registry. So, new patient being added, I can find them, click. Now they're completely, all their demographics are completely added. I can verify them in my EMR. Nice time saver there. But at the same time as I was meeting with them and going through their past history, I also had the hospital information system up, just having a look at what sort of recent tests they've had and whatnot to see if I needed to redo anything. And I said, oh, I see that you have been to a urologist. He said, oh, yes, I'm going to see him this afternoon for the results of my biopsy. Now, this is a slightly morbid story, but the results were not the greatest news, and so I ended up giving him the information. And because I had more timely access in some ways than my colleague. Benefit, though, to the patient is that now they're armed with that information, and when they go to the urologist later, they're going to be able to ask the appropriate questions.
Go ahead.
I was just going to touch on that too, more so to what Stephen was saying. Patients are, in my point of view as well, a huge driver for this, because we have patients coming into the pharmacy who want to know their information. They want to know how their treatment is going. They want to be able to see what we see. They want to be able to know, okay, so, you know, what are my blood sugar numbers? What is my cholesterol number? And what does that mean? And so being able to potentially develop software that allows patients to have more access, or allow us to provide that access more easily to them and educate them on those numbers is huge. And then second to that would be patient safety. For me, I feel like I'm able to provide much more kind of a total care, and the patient in turn has a much better care because I have all of the information I need to be able to do my job properly. And that goes across the board with any practitioner that has the full information in front of them. If it's not easily accessible, sometimes we may not quickly go to it if we don't have time, and that could, you know, negatively impact your patient. And so that's, for me, those are the two big drivers.
And the other thing about safety, and certainly safety was a driving force for us, but the thing about safety is it was something that our health board understood. So safety enabled us to get the resources that we needed to move forward. You know, when we said this is a safety issue, something bad is going to happen here if something doesn't change, then our administrators had to deal with it. So safety for us was certainly a driving force to be able to move forward.
I think that interoperability also gives us the opportunity to improve our quality. You mentioned about not repeating tests, and that's huge when you don't know what a patient has had done in emergency or what the specialist has ordered, and you're waiting on this faxed letter that will take months to arrive. It's helpful to have that central repository to be able to go and look, and it would be even better if all of that just lived within the electronic medical record and the patient, it followed the patient rather than being piecemeal.
So I think we've heard a number of things in terms of some of the drivers. We heard loud and clear, I think, Stephen, you started with this, patients as a driver for interoperability, but then also patient-centered care. So whether that's the patient themselves having access, or Amanda, you, as you finished off, having access to other things, or Keith, your example as well. And then I think, Kelly, Paul, you also talked about safety. And that goes with patient-centered care, obviously. Unsafe care is not very patient-centered. But at the same time, it provides a concrete set of drivers, I think. And I was reminded, Paul, by your comments, we did a survey a few years ago, a national survey with the Canadian Pharmacists Association of Pharmacists across the country. And we were asking pharmacists about their experience in using provincial drug information systems. And we got screeds of write-in from the pharmacists in BC in answer to one of the questions that we'd asked about comparing the world that they were in with PharmaNet and the world without PharmaNet. And because PharmaNet's been implemented in BC for many years, they're used to that interoperability. And so the screeds of write-in were, you know, I've never practiced in any other way. I can't imagine practicing in any other way, and it would just be unfair and unsafe to do that. So it was interesting to see the level of really a visceral reaction that we got to that and the value that was seen. But we know that there are bumps in the road as well. There are barriers, there are challenges, there are also opportunities to wiggle your way through those barriers and challenges. Amanda, do you want to start us off in terms of, from a clinician perspective, how you see that work?
Definitely. So, I mean, I think that the opportunity is that having clinicians, regardless of which program you work in and across programs, all being able to look at the same information and know that it's the same is absolutely the best plan for the patient. It's going to improve the access to the care. It's going to allow us to be more timely. It's certainly more safe, and it's more efficient, and it's really the best way for us to do that. And I mean, I'm thinking about a situation the other day where I feel like medication reconciliation is the bane of my existence, and it doesn't seem to matter how much energy I put into it, I never get it right. So I, discharge a patient from the hospital has done what they're supposed to do by faxing the copy of the discharge prescription, and I try and reconcile it with my list that lives in my electronic medical record, and I still do it wrong when the pharmacy asks me to update the prescriptions. And so when we think about all of these different sources of information and all of the people that are looking at their own source, it just feels so unsafe even just to talk about it like that. And so to be able to think about a day when we can all look at the same piece of information, I think will just make things so much better for patients. In terms of barriers, I mean, as I'm listening to everyone else's experiences, sometimes I feel like we're so far behind in Manitoba, and I don't know if that's an all the time statement, but that's how it feels sitting up here right now. And I think one of the challenges is that we've got different degrees of optimization, different degrees of system accessibility, and not everybody's on the same page. Working in a private fee-for-service clinic, people in Winnipeg and across Manitoba are able to have an interface with the private labs to get their labs into their system automatically, whereas in our context of working for the health authority, we're not quite there yet. We have access to our electronic health record that is pulling in information around dispensing and diagnostic imaging that's been done in hospitals and laboratory investigations and presentations to hospital, but only one hospital in Winnipeg. And not all providers have access to that. So you're really creating this kind of imbalance and then thinking about how do we, once we get to the point when everyone is able to access it, how do you ensure that everyone is engaged and on board and using the systems effectively when we're getting there in this kind of stepwise approach that isn't really equal across the board. And I see that as a big challenge as we go and try and optimize these systems that we're fighting so hard to make interoperable when getting there is challenging.
Anyone else want to jump in on some of the barriers, challenges, and opportunities for finding your way through?
One barrier I can touch on in Saskatchewan, and I think this would relate to really any province in the pharmacy industry, is the DIS integration with pharmaceutical dispensing software. So if you look at any given province, there may be 6 or 7 main pharmacy chains and then numerous independent pharmacies, and every pharmacy utilizes generally different dispensing software. And then we have to then integrate that software with our DIS system in that province. And so that causes a lot of headaches and a lot of work to have all these different programs kind of talking the same way, because even though we're doing the same job, you go from, and I've worked in I've worked with different software, dispensing software, and they communicate so differently. And so now that we're integrated in my pharmacy, and I'm one of the pilot stores for integration, I'm realizing some of the barriers to providing this type of service, or to have this type of service. So we struggle with getting every pharmacist on board in the province because they've heard from other pharmacists, or they know from other provinces some of the issues that have come up. And so either the corporate company, so even Loblaw, for example, we were slower to integrate because of some of the issues we've seen in other provinces. And now that we're integrating here in Saskatchewan, now that we're integrating in Saskatchewan, it's very slow. We're taking it one store at a time just to make sure that there aren't any issues in terms of patient safety or data quality issues. And so that's a big thing for us. And so that's a huge barrier in the pharmacy world.
So certainly, as Dr. McLaren said, our naysayers often are our barriers, right? But they're also the force that drive us forward to help us to try to work our way around them. And the problem with it is they're right in many instances. I mean, we all sit here, all of us, talking about different systems and different access and communicating with these systems when, you know, ultimately the solution is as plain as the nose on our faces. It has to be simpler. It has to be one system. It can't be different institutions or different health districts or different provinces, you know, adapting different systems. And that ultimately is the problem. And the naysayers are right. You shouldn't have to know 4 different passwords to access 4 different systems to go into it 4 different ways. They're right. So we, I think, certainly have to start to figure out how to make these changes to move forward.
Stephen, I think you wanted to jump in.
Sure, just 3, these are opinions, not facts, but over the years, observations. Procurement process, I think, has 2 large problems. Every time I've been involved in a project outside of our office where we just seem to focus and get things done, you start to look at a larger jurisdiction you're involved with, and the project gets too big too fast. And what you had as your scope, no one remembers day one. It's like this huge thing, goes nowhere, it's too expensive, can't be delivered upon. So the procurement process is wrong. And the other aspect of procurement I keep wondering about, I never see vendors very often at the table, and the privacy people are brought in as consultants. They're not brought in as part of the team meant to deliver a product. So I think if we have privacy people engaged as active participants in building something instead of consulting on it, if they got paid based on sales, maybe we'd have some different products put out there. That's one opinion, sorry. Second opinion is this industry, the medical industry, is too happy with fax machines. So we live and die by fax, and fax server technology just made it easier. So the challenge to technology people is make it as easy as fax and then get your value added built in. So we're not going to, this industry is not going to change to something that's more difficult than a process they already do. Make it demonstrably superior and as easy, and then you might get people leaning towards a change in workflows.
One thing that's slightly different from my take on this is it's more of an observation of when we did the implementation for the EHR. As a clinician, I don't think I really appreciated the concept of standardization, and I'm not talking standards, but I'm talking standardization. And you can all go to Marion's talk later. That's probably an ad. We were part of this together. But it really does strike me that even at the clinical level, understanding that standardization of process is really important. Having fields, for instance, we wouldn't be able to convert one EMR to another because we use workarounds all the time in EMRs. And we would put data into a field which isn't really meant to be there. Like, for instance, in my old EMR, we didn't have an easy way to document which pharmacy the patient went to. So we created an artificial alert that we would use to populate that. Well, if we ever wanted to convert that to another another system, we had no way of doing it because you're comparing apples and oranges. And so the point that I'm making is that standardization to a degree needs to happen first because the system is not going to fix that for you.
So you guys have all started to inch into where I'd like to go next, but before I go there, I will open it up also to the audience. So, you know, I could talk to these guys all day. We've only got another half an hour to do that, though. So if you'd like to jump into the conversation, if you've got questions, thoughts, and so on, please make your way to the mics so that everybody can hear you as we go. And while you're thinking about that, I'm going to move into my next question, which is there's a whole range of different people in the audience today. There are some people here who are clinicians, there are some people here who come from the vendor community, there are some people here who are implementers, there are many other people with many other hats on, jurisdictions and so on. So if you had advice you can pick which group you're giving advice to. I'll be nice on that front. But if you had advice on, what would make it easier? What would help this along? What would smooth the path? What would it be? And Paul, maybe I'll ask you to start us off.
I think, I don't know. With me, this is something that's very difficult. We have, when we talk about this interoperability, we're talking about so many different things. And with us, for example, we're using, in Saskatchewan, we're using different softwares that we're using, or different programs that are all kind of giving us different information. But at the end of the day, you want to be able to make something that, as you said before, Kelly, is to have one access point. So make it as easy as possible. Make it so that you can get into everything you need to see in one access point, so that I'm not having to look in my DIS software this way, looking up labs over here, that everything is available easily and without restraint that way. That's the biggest thing for me. And I think secondly is making sure that there's training available prior to launching these types of software. So we've had issues in the past where these programs are being launched and then clinicians are expected to utilize them, but not really know how to utilize them to their full potential. So there's lots of ways that you can utilize some of these programs, and some of them have some really cool tools in them, but if you're not familiar with how to access those tools or utilize those tools to their full potential, you're not getting the full use out of it, and you may not really see the benefit in that and may not use it as much as you should. So those would be the two big advice pieces I would give.
Great. Who else wants to jump in with advice?
Mine would be both from development as well as implementation, the importance of clinician involvement in implementation, in creation and development of these ideas, that it's important to have clinicians from a variety of different professions who are actually going to use these tools to be involved in the planning. But around implementation, I think it's also really important to have clinician champions at sites, and because we want, if we're going to go to the effort to create these tools, or to ideally create one tool that houses everything, we then want our clinicians to use them, and to use them in a way that's going to move our practice forward. So we don't want these great systems to just be doing the same work we were always doing. As an example, when we went live with our electronic medical record, people loved their fax machines and didn't trust the automatic faxing, so they would print out their referral letters and still then manually have them faxed through the fax machine. Even though that could all be done behind the scenes through the computer, they didn't believe that it would actually happen. So having the champions is really important, because we want people to sort of get past those insecurities. They're able to optimize their use of the tool and then move forward and actually do even better things than they were doing before.
Great, thanks. Anyone else want to jump in with advice?
I think you have to look at the flow of the patient in a particular clinical population. I think you have to understand where your patients go to seek care, and we need to try to be able to access that care and pull it forward. So we did what we called a needs assessment, and we tried to look at where our patients were coming in and out of the system across the continuum, where they were getting lab work done, where they were getting diagnostics done, how we were going to get that information from all across the province. And that's what needs to be done. We need to be following patients and understanding where they're going and what information is being, at pharmacies, what information is being gathered and how we can get access to it. I think we're looking at it from an IT perspective down, but we should be chasing the patient around the province and trying to figure out where they access care and how we can gather that information.
From a patient-centered perspective, and also partly selfishly because I'm switching from one EMR to another, I think the data needs to follow the patient. And,
Yes.
and I'm not talking PHRs here. I'm talking specifically the record that's in their electronic medical record. I can't get my old data out of my old system. So what I have to do, which is ludicrous as far as I'm concerned, I have my new EMR in front of me in one window, and I have my old EMR in the other window. And I go back and forth between the two so that I can have continuity. So to the vendor community, I challenge you to come up with some sort of solution to allow the information to go in and out of your systems easily. Please. For the sake of the patients.
I saw a lot of nodding as you were talking, Kate, so I think you're not the only vote on that one. Stephen, did you want to jump in? Or?
Again, just a thought and an opinion. I've often wondered why this hasn't been done, and maybe there's good reason for it. I just don't live at a level to know. If you are a major producer of data, so you produce reams and reams and reams of data, I don't know that the province of Ontario or a local LHIN or the country of Canada tells you how to map your output. So a specific example in Ontario is, I'm going to guess there's maybe less than a dozen major producers of lab data, or maybe 5 big labs in Ontario producing most of the lab data. Their dictionaries are monsters. They all have their own dictionary, and actually they have multiple forms of dictionaries. Hemoglobin with Life Labs and MDS, I think we've got 30 things we have to map at our end just for Life Labs, so hemoglobin shows up as hemoglobin across a continuum of patient experience over years. We have to do that for every source of data. So we've left 10 to 20,000 physicians in the province mapping things in their EMR constantly as the dictionaries from the senders change, when why haven't we locked down the 5 senders to map at the output to one common set? Is simple. Maybe we can get 80% tomorrow by looking at the Ontario lab form and saying hemoglobin is called hemoglobin and white count is called WBC. All your metadata can live behind the scenes. All your reference ranges, all those things can be plugged in there electronically. But that's what a hemoglobin is. And then the end users pull in hemoglobin and they map it and graph it and put it in tables. But it doesn't seem to be that way. And the same with the major players of hospitals. There's very few hospital systems that have their installs across Canada, but I'm not sure we're influencing the way they output so that we can have interoperability at the receiving end. And maybe I'm just ignorant of the rules and how it goes, but that's sort of an observation.
So just a reminder, if you want to join the conversation, please come up to one of the microphones. Otherwise, I'm hogging the airtime, and I'm good with that. But Kelly, actually, I wanted to pick up on something you said in your opening remarks, because we've been talking a lot about interoperability from the perspective of sending data back and forth. But of course, then there's what you do with that data, whether it's clinical decision support, whether it's analytics. So can you talk a little bit about your experience in that domain and what's worked well and maybe where some of the challenges have been?
So because we built our own system, essentially, we were able to build it the way we wanted it to be, and we were able to ask the queries that we had to ask every day to our patients with Crohn's disease and ulcerative colitis. So within our system, we built what we call disease severity indices. So for Crohn's disease, it's standard. It's called a Harvey-Bradshaw index, and for ulcerative colitis, it's called a modified Mayo. And both of them have 5 or 6 questions that you ask the patient every single time you see them. And at the end of the visit, you have a score of disease severity based on the queries that you've asked. The scores are graphed over time within our system, so I can go in and I can look at where I added a medication and what happened to the disease severity index. And the patient can see that information. So it's huge, because although a patient gets sometimes well slowly, and they notice things are a little better, they don't necessarily notice all the changes that have happened. So look, you were having 10 to 15 bowel movements in 24 hours, and now you're having 4 to 5. That's huge. This is how you've responded to this therapy. And we're able to graph that over time, and patients are able to see that. And it's really revolutionized the way we practice. The other thing it's done is it's standardized the questions clinicians ask at every visit. So every clinician is asking exactly the same questions, which we were all doing just about, but this is standard. Now we're all asking the same questions. Now we're all listing the medications and drop-down menus the same way, with dose, the same way, with how often the medication is being given, the same way. So it's standardized our practice across 12 clinicians, which again is huge. So we're just now, we have a new IBDologist in Halifax, and so we're just now starting to look at the research potential of this. What does this tell us over time about our patient population? So, you know, we're really pleased with the way we set things up, and we're just now starting to reap the benefits of that.
Great. And Stephen, oh, sorry, go ahead.
I was just going to kind of build on what Kelly said. So what the ability to be able to graph something is substantial for a patient. So with our lab portal, we have that same ability. And for me, when I'm having, when I have a visit with a patient, whether it's a medication reconciliation, or even if it's just a standard consultation on a new medication or a refill, and we go through and we look at their lab work, and we can actually graph how whatever you want to track, whether it's A1C, cholesterol numbers, it doesn't matter. You can graph and show that patient kind of the effect over time and how certain things over time have affected it, whether it was maybe they got really sick or they stopped taking their medication or they started a new one. You're able to visually show them the impact that has. And that has a huge effect on the patient because they can actually see what's going on. They don't just kind of hear what's going on. And to be able to visualize something is very important. And it makes a huge difference in their buy-in into what you're trying to get to them.
Great. Stephen, you talked about analytics a little in your opening as well. Do you want to jump in on this?
Sure. So this is one of the joys in our office is actually data mining. We'll do that for administrative purposes, who's seeing whose patients and covering each other off in a capitated model, so people like to be rewarded for the work that they do. We need to track what our allied health are doing, report to the ministry, so we use analytics there. But the best bit is the clinical analytics and asking yourself a question, trying to gauge how good you are at something like flu shots or pneumonia shots or whatever, Gardasil populations. Pick something really simple, kind of guess where you're at, and then run the analytics, and every single time you realize you're nowhere close to thinking you're as good at doing what you thought you did. So it's remarkable. And then you got to figure out, so we found a clinical care gap, how do we close the gap? And that often becomes the obstacle. But if you keep doing it, after you've done it a bunch of times, you're actually already thinking about, here's the manpower we have, here's the resources we have, here's who we can repurpose, here's how we can reshape what we do. Stop doing this stuff, let's do that. Now we'll run the data, and yes, there's a need, and we actually kind of know our next step of how we're going to unleash the manpower to solve the care gap. It's actually, we do it every single day. I run analytics every day in my office. Some of it I use just for efficiency so I don't miss coding something. As simple as, I'll do my own flu shots because the nurses are busy. So invariably, until I caught on, I would either miss writing down that I did the flu shot, or miss the tracking code, or miss the billing code. So now I do one thing. I just put in the chart that I did a flu shot. And at the end of every day, I just say, tell me who I did flu shots on. And the output gives me my list. And then there's an automatic script that says bill and track. And so now I've done my 3 tasks, having actually only done one piece of work and having the computer do the rest. And we've harnessed a variety of techniques like that in our system where our group will flag the next PAP, next mammogram, next colonoscopy, next FOBT, because none of the systems are smart enough to tell you when they are. So we have the humans do the one thing that they're capable of doing better than the machine, and then the machine sends out the reminders. You can grab your cohort of patients that are due for maneuvers. A group of medical office assistants called Wellness can act on all of those, and you basically remove a lot of that work from the clinician's hand, and all you've asked the clinician to do is the one thing that they should do is make a clinical decision and document it easily in the record. So those analytics spin behind the scenes every single day in our office, and actually what we've then realized is a greater hit on getting those preventive maneuvers done. And all of a sudden, we're not spending the time with clinical encounters doing them. So now we have better access because we have openings in our day, which has opened up for better service for our patients. So it all starts to dovetail in the things we're supposed to be doing in terms of providing access and better coverage, as well as actually doing more in terms of closing care gaps.
Great. Anyone else want to jump in on decision support analytics?
One little small thing just to pick up on what Steve was saying, even though we're not fully integrated yet, on week 2, I think one of my colleagues started to make use of the reporting software, if you will, or the reporting tool that's built into our new EMR. Because we had highlighted that we're cross-covering each other and we don't have all the data in there that we need, like medications, allergies, past history, and whatnot. But we thought that as a starting point, we'd look at how good we were at dealing with, say, populating allergies. Well, the tool that's built into our EMR is drag and drop. In 2 minutes, we were able to create a query that we can save, share, etc. And we quickly identified that, as Steve had pointed out, we're not as good as we thought we were. And we could actually identify which of us in the clinic were really bad at it, so we targeted each other, which was quite fun. But as a result, we were able to rerun that query a few months later to see the improvement that we've done in that process. And we're using this as an iterative thing. But the point that I would like to make to maybe perhaps the administration side of things, if you don't have full control over your EMR, EHR, or whatnot, put the analytics in the hands of the clinicians and the people that are going to be affected by this. Because if we had to go to some third party to be able to say, can you pull out the list of people who, it doesn't, the engagement isn't there. And our engagement has gone up so much because we're able to actually interact with the analytics tool ourselves. And I think that once we're fully integrated, we're going to really explode with the type of uses, hopefully similar to what Steve's been doing.
The power of both information and a little friendly peer pressure.
That's right.
Please.
So all this is music to our ears, I'm sure. And I was thinking a little bit from a little bit from an academic point of view. There's technology adoption models that say things like there's early adopters, the early majority, the late majority. When you listen to your peers who maybe aren't at the same level of IT sophistication in their practice as you are, how often is it that you're thinking, oh, I could solve that with my system, and it's really a change management issue on their side, or is it really because the technology is inhibiting them from being able to do what they're describing they want to do? I'd be interested in your opinions.
Interesting question.
Yeah, great question. I mean, I think it's a combination of both of those things. So I think, right, Stephen was saying about our reliance on fax machines, and that our task should be to make a tool that's as easy but way better. And so I think that that's part of the challenge, is that it's hard to get the later majority, but it feels like everyone else, to get on board, when, as much as I think that the tool is actually easier, and that there's so much benefit if you would just put the blood pressure in the little lab section, that will give us way more benefit than just typing it in your note. And it's the same. It's been 3 years and I still can't convince my colleagues that it's the same amount of effort. And so I think it's both. I think the systems aren't intuitive enough as of yet for the clinicians that are struggling to make it feel part of their day.
Anyone else want to jump in on this one?
Yeah, I think I agree. I think it is kind of both. I think generally speaking, the system is there and it has everything that they maybe don't realize it has, and part of that is educating, the clinicians as to what this can do, and that touches back to the point I made before about training. And I think that not only do you have to train them, to let them know what it can do, but then as leaders in utilizing this software, you also have to go out there and spread the word and showcase how important and how useful it is and the effect it's having on your patients. And so in a lot of provinces, they do have peer networks that kind of have this type of process. And when I'm doing, mentorship through my peer program, you go from someone in a pharmacy, for example, is fully on board and using a program, and another practitioner is not. But then when you get there and you start going through it, the other practitioner all of a sudden is like, oh, that's pretty cool. Maybe I will like using that. And I mean, it's just a matter of sometimes just having someone there to help you along the way can make a huge difference in that.
And there's also the huge time commitment to the shift, right? Mm-hmm. So to go, for example, from paperless to electronic, it's huge, and to go from electronic to electronic, it's huge. I mean, we had 1,700 charts that had to be dealt with, and we had physicians saying to us, but you can't get rid of that information, I need it. So, I mean, it's a real huge amount of effort to move forward, and we had to find a place on the permanent health record where that information could live. And then we hired 4 summer students on a grant to go through 1,700 charts and pull out the pertinent information that these physicians told us that we needed. So it's huge. I mean, this is not a little undertaking. This is not I just wake up one day and I open a computer and I'm now online. I've got 20 years of information in paper charts or in another EMR. What do I do with that? So that, I think, is the biggest step to moving forward.
So I want to switch gears a little bit, and several of you at the beginning talked about the patient as a driver for interoperability. And in the focus groups we've done with patients, we often hear patients saying, absolutely, this is something I'd really like access to my labs, I'd really like access, if you're a parent with young kids, to immunizations. You get the whole story about the camp forms and all of that good stuff. But they also say, often, but what would my doctor, my nurse, my pharmacist think? Would they be on side? Because many of the functions they're interested in are a two-way street. If it's something like an e-visit, it involves a communication with somebody else as well. So can you talk a little bit from your experiences in terms of your thoughts on where patients are at, and also on what would need to happen to make that marriage work, to have patients have access to information? And Paul, I know you wanted to jump in.
Yep, sure. So having access to this information and being able to provide it one-on-one with patients when they come in, you realize how much they value that information. And in Saskatchewan, because we now have the EHR viewer for clinicians, they're now developing an EHR viewer for patients. And so it's going to be a portal for patients to be able to access their health information. The trick now is identifying what information can you give them and they understand, and how that's all going to work. And that's still very early on. They're working on how that's going to happen, because you can't just give a patient all these lab information, for example, or test results, and expect them to understand what that means for them, and not add more worry or add more concern or what have you. So you have to make sure that you're very careful in how you do that. But at the end of the day, patients want to know, they want to be more involved in their health care choices, and they want to know what's going on with their body or what's going on with their medications. And so having access to as much information as possible is extremely important, and having access to it easily. And so, Saskatchewan's noticed that, and that's why they're developing this portal. And I think it's only going to become more and more, if I were to go to a doctor's office, I would like to know what that test meant, and not necessarily just what, that perception from my practitioner, what they think it is. But I'd actually like to know what that result is, so if I wanted to look into it further, I could. And so I think it's huge. It's a huge driver for sure.
Great. Keith, you wanted to get in on
I'll
this?
I'll provide some counterpoint maybe. Interestingly, I'm a big proponent of the concept of electronic personal health records. I had the opportunity a number of years ago to work with the e-health group of the National Research Council, and the area of research that we were looking at was personal health records. The fascinating thing to me is that there's a desire to have access to your data, and at the moment we listen to that desire and we answer that call by creating tethered PHRs, I would argue. So in many ways it's not really it's not always a patient-centric tool that is out there right now. What it is we as clinicians need maybe perhaps some data and some communication between patients and ourselves. Maybe it's collecting blood pressures from home or whatnot, and we reciprocate by providing some advice back to the patient. But I think that we've seen a number of examples over the years where personal health records of those type work in some instances and don't work in others. I mean, we look at very, very obedient, and I use that term in a very facetious way, but obedient patients that will come in with their blood-stained diabetic records because we ask them to collect their lab data, but yet they're collecting this data, but they're not acting on it because we've asked it. It hasn't had necessarily the intrinsic meaning for them. I think that where things will go and where we will get that intrinsic desire by patients is when we give them almost the raw data and very easy ways so that another group can go and build the app that provides that consumer-centric kind of approach. What's going on in BC right now where people can actually access their lab data is quite fascinating. I think that's very telling. People are interested in accessing it, but does it change outcomes? And that's the challenge, I think, to the research community to figure out after the fact. It's one thing to want to have access. I mean, everybody loves watching reality TV, but it doesn't mean you want to be the person in that television. And I think in some ways health data has the potential to act a bit like that. And so While I agree that PHRs are a great way to go, I think we need to really let them embrace the data and let them build the value add rather than us telling them what we think the value add should be for them.
I think that's an interesting lesson, Keith. We've actually been doing some work with the group in BC on evaluation. And basically in BC, you get exactly the same information right now as your doctor gets. It's the same profile that goes out. And what we found, comparing people who had accessed test results that way with ones who hadn't, matched for was your lab result abnormal and so on, was that the group who accessed results online were more anxious before they accessed the result. There was no difference in anxiety after the result access, and they got their result much sooner, and they were more likely to have gotten their result. So effectively what seems to be happening is you're shortening the period that patients are spending with an anxiety state. Which is an interesting consequence. There's also some very interesting results in terms of the degree to which it changed behavior in terms of in-person visits to receive results, that kind of thing. What we don't have yet, it's still early days, is the sort of long-term outcomes. But Michael Golby, who's chair of our clinical council, told a story recently about patients who are now accessing their HbA1cs in particular online. And because they're seeing it and because they're knowing it's high, they're actually not coming in to see him until they've made behavior changes that drive their HbA1c down. And then they'll come back in. So it's like, you know, I don't need the lecture. I know what you're going to say. I'm going to make the changes, and then I'll come back to you. So it's an interesting N of 1 case example. So please join me in thanking all of our panelists.